Good afternoon, and welcome to Ask the Doc. This is the monthly show where we invite our audience to ask questions of our experts in Alzheimer's disease and dementia. My name is Dr. Megan Whitbrocht. I'm the Associate Director of Education here at UCI Mind and the co-host for this program. Just as a reminder, UCI Mind is one of 38 Alzheimer's disease research centers federally designated by the National Institutes of Health. Today's topic is going to be about the new agitation drug to treat Alzheimer's disease. My guest is Dr. David Sultzer. He has been on the show at least once before, about 2 years ago, and so we're excited to have him back. Dr. Sultzer is the Clinical Research Director for UCI Mind. He leads the clinical core at the UCI Alzheimer's Disease Research Center. He's a physician, a psychiatrist, and a professor in the Department of Psychiatry and Human Behavior in the School of Medicine. Dr. Sultzer received his medical degree from the University of North Carolina and completed a psychiatric residency at UCLA. After a long tenure at UCLA, we were fortunate enough to get Dr. Sultzer at UCI and UCI Mind. He studies the neuropsychiatric symptoms that occur in Alzheimer's disease or that promote the risk for Alzheimer's disease. Welcome, Dr. Sultzer.
Good afternoon, Megan. Nice to join you today.
Yes, thank you for coming back. Okay. Earlier this year, brexpiprazole, a drug to treat agitation in people with Alzheimer's disease, was granted FDA approval. And this is the first drug approved to treat agitation ever. So I brought you on to tell us a little more about it, but maybe we can start with the basics. Can you tell us what agitation is and why it's difficult to manage?
Sure, absolutely. Agitation is one of the non-cognitive symptoms of Alzheimer's disease. We think of memory, perception, problem solving as being the core symptom cluster in people with Alzheimer's. But we now know that there are a whole host of neuropsychiatric or behavioral symptoms that are fundamental parts of the illness itself. So things like agitation, irritability, anxiety, et cetera, are parts of the Alzheimer's syndrome. That agitation is generally defined as either motor symptoms or physical or verbal aggression. So angry outbursts, for example, or sometimes physical aggression and increased motor activity. Folks who are really aggressive pacers, if you will, lots of motor movement that isn't really particularly goal-oriented, can be pretty distressing. This occurs in 30 to 40% of older adults with Alzheimer's disease, usually more later on in the course of illness. And although there may be some early symptoms, interestingly, even before people have memory difficulty.
And what causes people to experience agitation in Alzheimer's?
Yeah, it's complicated. And there's been a lot of recent work trying to understand this because our ability to develop treatments for anything really depend on understanding what's causing it in both brain and environment wise. And that agitation is caused, you can think of it as being sort of a constellation of both brain function. And we've done some work as well as others demonstrating that when certain parts of the brain in Alzheimer's disease aren't working properly, that group is more susceptible to behaviors like agitated and aggressive behaviors. But there's also other important contributions as well, everything from environmental issues that, particularly in places like long-term care facilities where the environment can be really frustrating for people. And when folks respond to frustration, sometimes it comes with some agitated behaviors as well. And then there's psychological issues. Interestingly, people who have a lifelong history of being more aggressive, if you will, are more susceptible to developing agitation late in life with Alzheimer's as well. So it's this constellation of different kinds of contributors to the syndrome. I think most importantly is the brain contributions are important because those are opportunities to develop treatment targets. And there's been a fair amount of work done recently to better understand what specifically is going on in the brain with agitated behaviors to identify opportunities for intervention.
Yeah, that's a nice segue. So prior to 2023, what treatments were available for agitation in people with Alzheimer's disease?
Sure. As most are aware, the medication treatments for Alzheimer's disease have not been particularly robustly effective over the years, and that traditionally atypical antipsychotics, medicines like risperidone, olanzapine, quetiapine, have been used to treat agitated or aggressive behaviors in Alzheimer's disease. And we've learned over many studies now, going back 2 decades, that the magnitude of benefit from atypical antipsychotics, of the ones I mentioned, the magnitude is not huge, that it's a modest response on average. And we've also learned more over time about the side effect profile that is not as benign as folks used to believe as well, that there can be a fair number of side effects that contribute to additional morbidity with the illness. So it's kind of on balance, atypical antipsychotics have been shown to be effective, but only modestly so, and come with some side effects. So, this is now a change where a medicine has been FDA approved. Brexpiprazole 2 is an atypical antipsychotic, and it's not clear right now how much more benefit there will be from brexpiprazole compared to other atypical antipsychotics that have been used over the years. The general sense is that the side effect profile may be a little bit more benign, and that would be a distinct advantage.
Mm-hmm.
But there haven't been head-to-head trials, so we don't know exactly. And clinical experience with the medicine is still pretty limited because it's only been recently available for general use in the community.
So how does an atypical antipsychotic work? Do they have the same mechanism, or each one work a little differently?
Each one's a little different, and it's a good question because that's really the key to identifying those that are most beneficial and least harmful. In general, the atypical antipsychotics have effects on neuroreceptors in the brain that include two primary classes. One is serotonin receptors, and the other is dopamine receptors. And each of those categories of receptors has a whole bunch of different subcategories. And each one of the atypical antipsychotics has slightly different effects on the different subclasses of receptors. So one may have more dopamine effects, one may have more serotonin effects, some may have more serotonin reuptake effects, others may block certain kinds of serotonin or dopamine receptors. So there's some heterogeneity across them, but as a class, we kind of lump them all together.
And for brexpiprazole, who do we expect it to help in terms of at what stage in the disease, and who's the target population here?
Yeah, I mean, the trials were done in people with Alzheimer's disease and who met a certain threshold of agitated behavior. So, in clinical practice, we're going to be looking for, folks who have significant agitated or aggressive behaviors. So this is not to include people who have, everybody gets frustrated sometimes, including people with Alzheimer's disease. And with the challenges in responding and coordinating behavioral responses, people with Alzheimer's disease may be more susceptible. But we're going to identify those that have kind of, and not just short-lived symptoms, but those who have had significant symptoms that have an impact on safety or reflect a lot of distress that have gone on for a period of time. We're also going to want to look at, particularly if it's new onset, i.e. somebody who's not previously been affected by such symptoms, to be able to make sure there's not a medical cause promoting the agitation that's treatable. Things like pain, for example. Somebody with Alzheimer's disease may lack the capacity to ideally express themselves and may not be able to explain pain, for example, and that can come out as agitated behavior when they're really attempting to get their needs met. So we're looking for any medical things, infections, bladder infection, et cetera, that may be contributing to behavioral symptoms in Alzheimer's disease. And then we're starting with each of the medicines, and brexpiprazole as well. Starts with a titration with a lower dose and then increasing over a couple of weeks to get up to a more effective dose later on. So we're looking for people who, the kinds of symptoms that may respond include things like physical aggression, verbal aggression, and the excessive motor behaviors that I described previously. In the most recent trial indicated or suggested really that those with more severe agitation, particularly physical aggression, may be the most responsive to brexpiprazole treatment, although there was some response to all of the symptoms that I've just described over the course of treatment. So that's kind of what we're looking for.
Mm-hmm. Yeah, that's really important. That's great. I mean, if it could alleviate some of those symptoms of physical aggression, that has to be very difficult to manage.
Absolutely. And we need to remind ourselves that, these symptoms are really significant parts of the Alzheimer's disease syndrome. And when you think about what promotes caregiver burden, caregiver distress, institutionalization, it's not memory problems. I don't mean to trivialize it. Memory problems are obviously important, but things like agitation, anxiety, irritability are really important aspects of the illness.
Mm-hmm. So we actually have a question from the audience that I think fits nicely. So Mark Applegate is asking, would this drug be appropriate for someone with Lewy body dementia?
Yeah, it's a good question. That there haven't been controlled trials of brexpiprazole for Lewy body dementia or behavioral symptoms in Lewy body dementia. That said, and the neurobiology of Lewy body dementia is different than Alzheimer's disease. So it's certainly possible that the response would be somewhat different. But it certainly is a reasonable consideration just based on clinical practice. And that's something that, clinicians will need to figure out over time. That a challenge with Lewy body dementia is folks with Lewy body dementia tend to be particularly susceptible to some of the side effects of atypical antipsychotics, particularly a syndrome called extrapyramidal symptoms with rigidity, tremor, can be associated with falls as well. And obviously that's something that's not good. And it seemed that in the brexpiprazole trials in Alzheimer's disease, that the extrapyramidal symptoms were not that common. They weren't non-existent, but they may be less than other antipsychotics. So it's possible that Parkinson's dementia with behavioral problems or Lewy body dementia that brexpiprazole may be a reasonable consideration. Although at this point, that's a clinical guess and certainly worth trying and considering, but we just don't know the answer to that yet.
And so as far as you know, there are no current clinical trials being done with this drug in people with Lewy body or Parkinson's?
No, not to my knowledge. It's possible there's something going on that I'm not familiar with, but brexpiprazole, every drug has its history of the drug development program it's part of, and brexpiprazole has already been FDA approved for people with schizophrenia. It's an atypical antipsychotic. So it's been on the market for symptoms associated with schizophrenia for quite some time now. So the trials were done for agitation and Alzheimer's disease, identifying that as a particular target. And then it took, 3 trials that included just over 1,000 participants to develop the data set that was submitted to the FDA for agitation and Alzheimer's disease. So that's where sometimes drugs are very good for other symptoms, but we just don't have the trials data, and there's not an opportunity to have robust trials data for every clinical syndrome. So, that's where, clinical wisdom comes to play a role and identifying candidates who may be reasonable to consider. Then it would be an off-label treatment. And obviously you need to be cautious then, but to identify those candidates who may have a response, and it wouldn't be an unreasonable clinical approach.
Mm-hmm. And then what are some of the side effects associated with taking brexpiprazole?
Yeah, I've mentioned some of them. Overall in the trials, the side effect profile was reasonably benign at the doses used in the study. There was a little bit of sedation, a little bit of dizziness, a little bit of GI symptoms, diarrhea in particular. And those are happening in less than 10%, or usually dose related as well. And that's where the medication is started at a lower dose and then increased over a period of 2 to 3 weeks, like I mentioned, to make sure that folks will be tolerating the medicine reasonably. The other symptom profile that we're concerned about is the extrapyramidal symptoms. I've already mentioned and won't belabor, but that's something that can really have an impact on things like rigidity falls and things that are medically compromising. And brexpiprazole, the signal for extrapyramidal symptoms in the trials was relatively low. So I think that's a good sign. We also need to keep in mind that all atypical antipsychotics carry a warning from the FDA about the mortality risk. And coming from the older evidence from atypical antipsychotics that have been prescribed over the past 2 decades, there's evidence that taking an atypical antipsychotic, an older adult with dementia and psychosis or agitation, is at risk for mortality or death over the next period of time that may be extended. The magnitude of that risk is relatively small, but obviously when it comes to mortality, we want to be very, very careful about that. So that's something that was, there weren't enough people in the brexpiprazole trials to know, was that risk higher, lower, about the same than other atypicals? One would presume, just based on the molecular structure and clinical practice, that it would be about the same. So we want to be aware that medicines, including brexpiprazole, can have some uncommon but serious side effects. Hence the importance of choosing people wisely to treat with the medication, because it comes with some risks.
And why is the mortality risk higher in these atypical neuropsychotics?
Yeah, it's a great question, Megan, and people have been trying to understand that. If you look at, again, it's not that common. So the evidence that we have, the evidence base, is not huge to be able to say, aha, it looks like this is what's happening. That the causes of mortality have varied mostly across infectious illnesses like pneumonia, and that's what older people die from, unfortunately. So it's not clear that there's sort of a smoking gun for atypical antipsychotics. Some people believe that, folks taking these medicines tend to be activated, and that's part of the treatment goal, is to reduce that excessive activation, movement, et cetera. And older people, when they're sitting more, actually are at risk for stasis, venous stasis in their legs, et cetera. So it's possible that that's related, but that's pure speculation. The short answer is nobody really knows. And it looks like the causes of death have been quite varied and typical for the mortality of older adults in general. So it's not a clear, specific antipsychotic mechanism.
So then when would you typically start and stop a patient on brexpiprazole?
Yeah, I think I've alluded already to selecting people who may be appropriate for treatment. We're going to, again, identify those who have persistent, significant agitated or aggressive behaviors that are contributing to safety concerns, that are contributing to distress, that are contributing to basic care needs that people are trying to provide. And then we're going to consider the medical evaluation, and also to identify those who may respond to a behavioral intervention. As I mentioned at the top of the hour, that environmental factors can play a role in contributing to agitation. So looking at, are there things going on in the environment that are agitation-ogenic, if that's a word, to be able to, to help improve the situation. There's also evidence that working with caregivers, including in nursing assistants in skilled nursing facilities, to understand what the behaviors are and how to handle them in a behavioral way, a non-pharmacologic way, is can be really beneficial. And that's an area that's really going to be important going forward, because the solution to these behaviors isn't always medications, and that all medication treatment should be done alongside, be partnered with these behavioral interventions as well. So we're going to select people who we have provided a reasonable behavioral intervention, and symptoms persist. If the behaviors improve with the behavioral intervention, then meds aren't needed. So we're going to select wisely in those who clearly need it and haven't responded to non-pharmacologic interventions. And then stopping, it's a little, I think you mentioned stopping. I don't want to cut you off there. Yeah.
Yeah.
Stopping is a little bit less known because most of the trials, look at, they're about, 2 to 3 month treatment studies to look at benefit, not what happens later on. And the field's been, because risk is also related to length of time on drug, we want to be able to discontinue meds. And the general sense is if people have been symptom free for a period of time, like several months, it's probably reasonable to consider treatment for a few months, depending on the case. But if somebody gets better in the first week of treatment, it probably wasn't the medication anyway. So to be thinking about those kinds of issues and consider a trial for a few months. And if somebody's doing much, much better over that period of time, then to taper them off the drug so people aren't on these medicines forever. But nobody really knows. And we published a study going back a bit, looking at discontinuation. And, when you discontinue these meds, some people will have the agitation recur, but it's certainly not everybody. So it's worth a consideration. And those who did well in that trial were those who really had no residual symptoms. They were really substantially improved on the medication. But we'll need to know more about that, again, based on how clinicians experience that, as now more people will be treating folks with these medicines.
Mm-hmm. You mentioned behavioral interventions. What are some common behavioral interventions that are being done now?
Yeah, we think of them as really focusing on three things, if you will. One is the patient, the person with Alzheimer's disease. The second is the caregiver, and the third's the environment. And in each of those domains, for the patient, we're thinking about recognizing what things are distressing to them, and to be as calming as possible. There's a tendency, as you can imagine, when a loved one is agitated, there's an interest appropriately in trying to calm them, but it can be really distressing. And if you look at care partners of people with Alzheimer's disease with agitation, they're a very stressed group. And so we can talk about be calming, but it's very difficult to do. So we really work with patients and caregivers to understand what can be calming environments. For the person with Alzheimer's disease, it may be just separating them from a situation that tends to be cause problems for them. And like I mentioned earlier, for care partners to be able to talk about what symptoms are, some educational interventions so they understand what the nature of these behaviors are and what some strategies can be. For example, distracting somebody who's caught up in something that's really upsetting to them, just separating them from that environment can be helpful. And then the environment, I've mentioned already, that just to be able to identify those things that may be contributing. So we're thinking about things in those three domains. And there's good evidence that putting together a thoughtful plan that involves looking at those three domains is patient-centered. Everybody has their own issues, and to be able to identify what's best for an individual person and then implement that plan, check it out, see how it's doing over a period of a couple of weeks, for example, before moving to medication, unless there's huge safety issues, in which case it's almost impossible to implement some behavioral interventions. But that's far and away the minority of people with agitation.
Is this medication available broadly now?
Yes, yes.
Great. And I guess my next question is, and probably my last question, are there other treatments or medications for other symptoms that people should look into, or can we talk a little bit more about that just to kind of finish us off?
Sure. It's been a complex landscape, as we've both alluded to now over the past decade or so, for agitation or for other neuropsychiatric or behavioral symptoms in Alzheimer's disease. In the agitation realm, there's been work done looking at SSRIs, or serotonin reuptake inhibitors, that are typically used as anti-anxiety or antidepressant medications. And there's a large trial with escitalopram going on right now for agitation in Alzheimer's disease. An earlier version of similar work looked very promising, so we'll likely hear more about that going forward. This is now agitation. A couple other medicines like dextromethorphan is a compound that's been in trials for a while now. Pimavanserin is another compound that's been approved for psychosis in Parkinson's disease and has been explored in other dementias as well. So it's a rich area for treatment development, although many of these treatment trials have not been ideally driven by understanding the molecular pharmacology of agitation. So that developing understanding of how the brain works and medication development go in parallel, and that's been less than ideal thus far, partly because we haven't had good treatment targets based on brain imaging, for example. Also, some work with cannabinoids, for example. Cannabidiol has been looked at for agitation and Alzheimer's disease. Then for other symptoms like irritability, anxiety, depression, there's been a handful of trials. There's no medication that's FDA approved for those circumstances in Alzheimer's disease specifically, but clinicians have historically tinkered with those treatments and have had modest success. There have been a few trials of antidepressants for depression in Alzheimer's disease, interestingly not showing dramatic benefit, and suggesting that depression in Alzheimer's disease is probably different than depression in other circumstances, traditional DSM, major depressive episode, for example. A final syndrome that's been interesting is apathy. That we tend to think of apathy is not often a focus of treatment, but particularly early on in Alzheimer's disease, there's this interesting observation that apathy may be one of the first and most significant symptoms early on in the development of Alzheimer's disease, in some people perhaps before they develop memory problems. And that family members will describe being sort of emotionally widowed, if you will. They're not sad, they're not depressed, they're not hopeless, helpless, etc., but just a bit of emptiness and less connected to the world around them. And that too has been, it promotes a lot of additional morbidity with the illness, just less engagement and less opportunity to connect with things that tend to be emotionally stimulating in a good way and providing good brain health rather than being sort of isolated, and the apathy can contribute to the isolation. And there's been some work in that domain with stimulants, interestingly, to look at with some evidence of benefit. So that's something with when people with Alzheimer's disease have significant apathy, we'll consider a stimulant trial, for example, to see if that can be helpful to them. And it tends to be fairly benign. That too is off-label. It's not FDA approved. So again, it's a rich area for treatment development, acknowledging that, we're currently in 2023 at a place where we're going to have a whole host of new medicines online for treating Alzheimer's disease per se, perhaps even before symptoms develop, and developing symptomatic treatments for memory impairment, for example. It's a whole new world right now. But, a high proportion of people, there's still, 6.5 million people in the United States with this illness who have these symptoms that really drive a lot of the morbidity of the illness and institutionalization and caregiver distress. So it's really going to be an important area going forward. And there continue to be thoughtful trials. So I'm hopeful about that, particularly as we can develop a better understanding of optimal treatment targets.
Absolutely. And, I think the approval of this drug sort of got buried in the lecanemab, donanemab, aducanumab story, but this is a really important medication to help people.
Exactly. And we'll see, as the brexpiprazole trials showed, not everybody was cured of their agitation, for sure. And that's what we'd expect, actually. But anything we can do to improve the magnitude, the severity of these symptoms or their frequencies is a huge benefit, particularly when it comes to quality of life and allowing people to, institutionalization decisions are made based on behaviors, not memory. That's a broad statement, but I think you can appreciate why that might be. So they remain really important treatment targets.
So we actually had a few questions pop up in the chat if you have a little more time.
Absolutely.
And you talked about this previously, but maybe you can reiterate it. One woman is asking, my mother has anxiety and grinds her teeth and has facial pain from TMJ. Is this treatment useful to deal with agitation and anxiety?
Yeah, that's a great question. I think similar to like I mentioned earlier, that the goal there would be to treat the TMJ and the pain. That can be difficult, I acknowledge, but it doesn't make a whole lot of sense to use a medication to treat the consequences of a primary underlying medical issue. So without knowing what her experience has been with treating the TMJ and pain, that would be the first start. If it turned out that persisted, regardless of optimal medical treatment for TMJ and pain, then it'd be worthwhile considering it. But I'd really be cautious in that, for example, if there are any extrapyramidal symptoms that could potentially exacerbate the TMJ because of the rigidity in the jaw, that's out there a bit, but it's something that just comes to mind. So there, I think the focus is on TMJ and pain, and considering medication treatment for the anxiety or behaviors to be, or the sleep challenge, which I'm guessing is a problem as well, to be secondary considerations.
And then our last question, you had mentioned cannabinoids. Can you talk a little bit more about cannabinoids as a treatment in Alzheimer's disease and what symptoms specifically they're targeting?
Yeah, that too is a great question, and it's been an interesting history in that there have been off-label and just people have considered cannabinoids. Remember, there's kind of two different kinds: the THC kind that has psychoactive effects that are more notable, and then the cannabidiol that has more some anxiolytic effects without the traditional psychotropic high of THC. So, and there's been some work done in both areas. Most recently, and probably most importantly, it's been either a combination or with cannabidiol, the latter category of medicines. And cannabinoids, we call it that because there are somewhere around 100 different psychoactive compounds included in the cannabinoid umbrella. So it's been messy to identify which of those to best consider as a treatment opportunity. A study that's going on that's sponsored by the Alzheimer's Clinical Trial Consortium, it's just getting started, is looking at people with very late stage Alzheimer's disease who are in hospice care with a combination, I believe, of cannabinoids in order to look at beneficial effects there. So at this point, there's not been a consistent cannabinoid candidate that has been tested and demonstrated to be safe and effective. It's still a bit of the Wild West, unfortunately. But because of some evidence of benefit based on either clinical experience that people have had or some smaller trials, it's an area for development. So we'll be hearing more about that. I think at this point, it's hard to say, gee, they work or they don't work. But to understand that in the not too distant future, we'll know more about that, and particularly what cannabinoid species, if you will, are most beneficial. So it's just a work in progress.
Great, thank you. So, Dr. Sultzer, thank you so much for joining us again on the program. This was a fantastic episode. I learned so much about this medication, and I hope our audience learned a lot as well.
That's great. It's been great to be here, Megan, as always, and I hope the attendees got what they wanted out of it. So we'll continue on.
Yes, I think they did. And I want to thank our audience too for joining us and asking so many great questions. You can access this, Ask the Doc, and others by visiting mind.uci.edu/mindcast. Next month, we'll be chatting with Dr. Karen Lincoln about health disparities. And in the meantime, to learn more about research at UCI Mind, you can visit our website or consider signing up for the UCI Consent to Contact at c2c.uci.edu. Take care, and we'll see you next month. Bye-bye.